Hello, everyone. Welcome back to your CCS Exam Prep course. It's Wednesday, May 7th, 2025. And today we are going to be focusing on Domain 3, which is provider queries. Now, one of the things that I have been told over and over again by several people is that if you don't query on your job, domain 3 can be a little challenging. So, my goal tonight is to help you, number one, understand the query process, but how it applies. But then I also want you to walk away with some next steps for yourself. According to the content outline, this section is 9 to 11%. Um, and, the thing is, if this is an area that you have not prepared for, it can really throw you off. I want to just reiterate. The content outline provides the floor of what you need to know, and you have to take your knowledge to as close to the ceiling as possible by doing additional study based on what you as an individual need to focus on. So, at 9 to 11% of the exam, the query process domain 3 has three tasks. Number one, identify the elements of an ethical compliant query. I like how they say ethical and compliant. AHIMA has a code of ethics for members in general, but then they have the code of ethics, the standards of ethical coding, which is covered in domain number 4. So hopefully you see that AHIMA's test is designed where the content can be traced to an official reference. And so I want to make sure I make that extremely clear tonight. Number 2, determine if a provider query is compliant. And compliant is it's non-leading. It contains appropriate clinical indicators. And then number 3, analyze current documentation to identify query opportunities. So when I look at these three tasks, the first thing that pops out to me that you as a test taker, obviously, need to know what a query is, right? But you need to know what's meant by an ethical query, what's meant by a compliant query. If you are given a query, you need to be able to determine if the query is compliant. And then last and certainly not least, analyze current documentation. So you're going to be given documentation and you will read through it and identify if there's an opportunity to query. So, your number one reference, now there could be others, but your number one reference for domain number 3 is without a shadow of a doubt the AHIMA ACTIS guidelines for achieving a compliant query practice. Now, I was able to download the file from the Actis website. That file is available in Blackboard, but also you could just literally Google AHIMA Actis guidelines for achieving a compliant query practice. These two organizations were once like independent, and I want to say about a year ago, maybe 2 years. Life just keeps going by. AHIMA, excuse me, AHIMA purchased Actis. In fact, I think today was actually the last day of the Actis conference, which I believe was held in Orlando, Florida. Nonetheless, this document you really want to, how I recommended that you print and have the guidelines bind it together. this is something else that I would recommend that you print and bind together as well. And let me just say this: you're doing the downloading, you're doing the printing. You must do the reading and the reviewing and the understanding of the files. And as I've stated multiple times, if there is something in the file that you just don't understand, research it. That's how you learn and grow. All right, so this domain review is probably going to be just as long as like when I did half of domain number 1. And part of that is because I felt that I needed to do a little bit of anatomy review. Very briefly, I had planned on having a guest with me tonight, but she is not available. And so I'm going to continue on. So I felt like, in addition to the query process, you definitely needed to understand clinical indicators. So I do have some content tonight that's going to focus on that. I definitely recommend that you have pen and paper to take notes, and you will want to go back and re-listen to this review because you're not going to be able to grab everything, but I think that you will walk away with a little bit more solid understanding. All right, so we will end tonight with or in this domain 3 review with some sample multiple choice questions. There are 30 of them. Now, our class is 3 hours in duration. It probably will take me about 30 minutes to get through the multiple choice questions. So, with breaks included, I feel like this may take us the entire 3 hours, but we'll get started and see where we land. All right. So, why are queries important? Queries are critical for clarifying provider documentation. Now, I know one of you mentioned at the beginning of the class that in your job as a outpatient coder, you don't query because the clinical documentation improvement specialists do the querying. That is not the case at every organization. So, in the event you change organizations one day, I want you to be ready. So, queries ensure that the health record accurately reflects the patient's true clinical picture as well as the care provided. Accurate documentation, it drives coding, it supports coding, right? Which impacts not only just reimbursement, but also clinical outcomes reporting, severity of illness scores, and quality metrics. Now, I do want you to know right now, I'm going to say this multiple times. We do not query for reimbursement purposes. The goal is accurate documentation. Queries also help organizations meet compliance expectations from auditors, payers, and other regulatory agencies. And without proper queries, gaps or ambiguities in the documentation can lead to financial penalties, denied claims, and inaccurately publicly reported data. If you don't know this, CMS has this website called Hospital Compare or Compare, where they use public data to and other data to compare one hospital to the next. And so, as a patient, that's something that you may look at and say, "Oh, do I want to go to this hospital?" The other thing that I did want to mention is that what most organizations will do is take the AHIMA ACTIS document and develop their own query policy. All right, so who needs to know query guidelines? Well, as I'm sure you all know by now, query guidelines aren't just for coders. I think back in the day, coders did more queries, but as clinical documentation improvement specialists came into being, um, which were typically, but not always, registered nurse. I am not a nurse, and I've done physician practice CDI. And I've been able to do that because I understand what is known as the language of medicine, right? Med term, anatomy, all of that. Um, Prior to clinical documentation improvement, we used to have a process called what was it called? Concurrent documentation review. And I think concurrent documentation review turned into CDI. And some hospitals felt like nurses were better positioned to query the provider because they understand, clinical language. But I think it's like a secret that in our programs, I think about RHIT, RHIA programs, as well as AHIMA approved coding programs. They have courses in medical terminology, anatomy, pharmacology, and disease process. And if you look at AHIMA's website where they talk about the eligibility for the exam, they say it's recommended but not required. I'm going to tell you, just from having taken this exam myself, having a greater understanding of body parts and diseases and all of that makes you a little bit stronger. So queries aren't just for coders, they're essential for everyone involved in documentation and the revenue cycle. And so CDI specialists perform concurrent documentation reviews. That means while the patient is admitted to the hospital. Compliance and audit staff monitor whether or not we are complying with regulations. And providers who we send the query to should be responding in a timely and compliant manner. But then we have quality improvement teams who rely on accurate data for benchmarking and performance improvement. So, understanding how and when to issue a compliant ethical query ensures that all stakeholders work together to maintain the integrity of the medical record. So, what is a query? A query is a formal communication tool that is intended to clarify incomplete, conflicting, inconsistent, or ambiguous information in the health record. Queries should always be clear, objective, and non leading. So there's a couple of words you're going to hear multiple times: ethical, compliant, non leading. I'm sure you're going to walk away with those terms in your head today. So the query must be based solely on the clinical facts that are documented in the medical record and should never assume or suggest a diagnosis that is not supported by evidence. So I want to remind you of a reference that I told you I use to help with the clinical aspects, which is called the Merck Manual. There's a reason that the Merck Manual is inside of 3M, but you can purchase a physical Merck Manual from Amazon, or you can use the online um, Merck Manual because they have it on their website. So, properly structured queries help providers elaborate or refine their documentation, ultimately resulting in better patient care data, right? And that's something we all want because at some point in our lives, we are patients. So, what are the goals of a query? So, the main goals of a query are to resolve ambiguity. What that means is when documentation can be interpreted more than one way, it is ambiguous. Um, Another goal is to complete missing documentation. When critical details like specificity, severity, or POA is absent. Another goal is to validate clinical documentation. So, ensuring that the health record completely and accurately reflects the patient's condition, their course of treatment, and their outcomes. Now, um, please understand that queries are not designed to fish for additional diagnoses or boost revenue. You're going to hear me say that also multiple times. Queries are not for financial reasons. They are intended to clarify the clinical facts that are already present in the medical record. Now, organizations will have different names for queries, right? The CCS exam calls it a query, but some organizations may identify a query by some of the names that you see listed on the slide. And at the end of the day, regardless of the term, the concept is the same, right? It's a professional, that's us or CDI or quality, whomever, is seeking understanding, is seeking clarity, consistency, completeness in documentation without mm, challenging or influencing clinical judgment. And I say challenging because we don't ever want the physicians to feel like we're challenging their clinical judgment. But then also, we should not be influencing, which is another word for leading. All right. So let's see. When should you query? So, queries should be issued when documentation contains conflicting information. For example, you could have two progress notes describing two different diagnoses. When a diagnosis is incomplete or non-specific. So, an example, which you probably will hear a lot of people mention when they talk about the query process, which is heart failure. And they just state heart failure, but they don't tell us if it's, congestive heart failure, if it's systolic, if it's diastolic, if it's combined. And you should know by now that that information is needed to actually assign the code, right? Remember, what's that code category? I-50. We have codes for specificity in heart failure. But one of the things that I want you to understand is just because the physician didn't give us the specificity of the heart failure doesn't mean that he knows. And I need to I think I'm talking about that later in the presentation, but let me just mention it now in case I forget. So, there is a test, echocardiogram, that is used to help diagnose the type of congestive heart failure. And so I will leave it at that. And later in the presentation, I'm pretty sure that I have notes about it. Let's keep our fingers crossed. um, let's see what else. Oh, POA status is unclear. As you know, POA status can affect quality reporting and reimbursement. We're not querying for reimbursement, but as you know, we have to put the POA indicator on the claim form. And so we need to have clarity. Another reason is a clinical condition appears present through treatment. So remember those inpatient records that you were reading. So you see like they're treating something based on the treatment or the tests, right? But the condition itself is not explicitly documented by the provider. And so one of the things that I want you to understand is that we are simply giving the provider their own information, and then we're asking them to make a decision. What's the goal? The goal is to ensure the documentation accurately tells the patient's story. At the end of the day, that's the goal. All right, so let's review some examples of where queries are important or appropriate. And again, you're going to hear these examples probably we discussed multiple times this evening. But a provider documents heart failure but does not specify whether it's systolic or diastolic. It's a detail we need for coding. Pneumonia is diagnosed, but there is no organism such as bacterial or viral, which can affect specificity. And again, I want to emphasize that the query process is a journey in terms of understanding it. I firmly believe that if you do your studying, you will be able to answer the questions on the exam. Now, in terms of the real world executing the query, you would need to lean on your leadership to help support growth in that area. All right. And then lastly, um, there can be a situation where a dietitian evaluates or their documentation says severe malnutrition based on objective criteria, but the provider doesn't address or validate the diagnoses in their notes. Now, remember, and I don't know the number guideline, but it's in general coding guidelines. There is a guideline related to it's something like documentation from professionals other than the provider. So the provider being the physician, nurse practitioner, you could have the dietitian who is noticing that the patient has severe malnutrition. You could have a wound care nurse who's giving the death of an ulcer, and so you really have to remember the rules so you can determine if the rules state you can code it without the query or if you need the query. Okay. All right. So when not to query, there are important times when you should not query. When the documentation is already complete, consistent, and specific, don't query. When there is no clinical evidence to support additional clarification, meaning you would be fishing for diagnoses without a clinical basis, don't query. And when the purpose is solely to improve reimbursement rather than clarify clinical care. I think you all know by now that when we plug those diagnoses into the encoder and then we allow the grouper to group them together, we do know that some diagnoses will change our DRG from one tier to the next. And so you don't want to um, query for financial reasons only. It has to be based on the clinical indicators. Every query must be justified by clear clinical indicators and a true need to improve the documentation, not just show me the money. All right. So, as I mentioned, I wanted to provide you with um, a brief introduction to clinical indicators because I do feel that they are important for understanding on the exam. I want to take a 5-minute break to transition to this point. All right, we are back. So, first things first, I do want you to know that I've tried to put together this information in a manner that was understandable by individuals who have not had any previous training on this topic. So, it is not real deep. Okay. So, clinical indicators are critical in both the coding and the query process because they serve as the clinical evidence behind a diagnosis. These indicators validate that a diagnosis isn't being assumed or guessed, it's actually supported by measurable or observable findings. Clinical indicators can include things like signs and symptoms, laboratory tests, imaging studies, diagnostic procedures, provider assessments, or even documented risk factors. Now, you know how for what is it called? Inpatient coding. Now, remember the CCS is inpatient and outpatient. But for inpatient coding, for a secondary diagnosis, we have those criteria that have to be met in order to meet the requirements for a secondary diagnosis. I kind of see it like this information is what you need to know to help get to those codes. All right, anyway, without clinical indicators, documentation, and any associated query, risk being not supported and non compliant. And remember, we want ethical, compliant queries. So, some common examples of clinical indicators include lab tests, such as an elevated white blood cell count, which can often indicate infection or inflammation. Now, please be aware you, as the coder, cannot assign a code based on abnormal findings. The provider has to actually diagnose the patient. All right. So just because you see someone's white blood cells count increase, don't just say, oh, they got XYZ condition. That's not your job. Imaging findings like chest x ray showing infiltrates is often associated with pneumonia and sometimes bronchitis. Vital signs such as fever, low oxygen saturation, low blood pressure, which is also called hypotension, can signify some serious clinical conditions. When you have treatments that's initiated by providers, such as starting IV antibiotics or insulin drips, can suggest a clinical concern, even if they haven't diagnosed it. But let me just give another disclaimer. Just because you see somebody is on insulin or was given insulin doesn't mean that they're diabetic. And in fact, the guidelines coding guidelines state insulin given to temporarily control a patient's blood sugar doesn't mean the patient has diabetes. For example, I am an asthmatic. And when I have an asthmatic exacerbation that is not controlled by outpatient treatment, I often have to be admitted to the hospital. And they're pumping steroids in me, right? Not the oral ones, but the ones by IV push generally. And so sometimes my blood sugar goes up. And while I'm in the hospital, they monitor my blood sugar. So if my blood sugar does increase, they will actually give me insulin to temporarily, bring my blood sugar down because my blood sugar is generally not high. All right. The last thing is physician assessments that describe specific symptoms, physical exam findings, or other clinical impressions supporting the diagnosis. So, something I want you to think about is, remember how you were reading those inpatient records? And I mentioned, starting with the discharge summary, then going to the history and physical exam, then going to the progress notes. As as you're reading through those files, you should be putting together the pieces of the puzzle. And if there are some missing pieces, it could be an opportunity to query. So, why are these clinical indicators important? They're important because every diagnosis that we code must be supported by clinical evidence. Without the clinical indicators, the diagnoses could appear unsubstantiated. It could lead to audits. I said this before, but I'm going to say it again: audits, denials, or compliance concerns. Additionally, clinical indicators strengthen your decision to query. Clinical indicators ensure that queries are necessary, that they are fact based and reflect the actual clinical scenario, not just an assumption or an attempt to improve reimbursement. I told you I was going to say that multiple times because I feel like that's a question they could ask you on the CCS exam. And I want it to be clear in your head: you don't query for reimbursement. So, where do these clinical indicators come from? Well, they are found throughout the patient medical record. Some of the key areas include the ED notes, which capture the patient's initial clinical presentation, HMP, where the provider is going to summarize the patient's past medical history, current complaints, and initial findings. Those daily progress notes, which documents the providers' ongoing assessment and evolving the clinical picture. Consultation notes from specialists offering their focused expertise, right, on a particular system or a condition. And so when I talk about clinical indicators tonight, I actually am breaking them down by system just to make them digestible. We have operative reports, imaging studies, lab reports that objectively confirm findings. And then you have other documentation. We call it ancillary documentation, such as nursing notes, respiratory therapy assessment, and nutrition evaluation. All provide valuable clinical evidence. All right, so let's now dig into the different systems. So we're going to start with the respiratory system, and the respiratory system is the system that allows the body to exchange gases. Right, the heart and lungs work together to exchange the good and the bad oxygen. And so, clinical indicators that you're going to see from a respiratory perspective: chest X-ray infiltrates. Right, it's commonly seen with pneumonia or pulmonary edema. Again, just because you read a chest X-ray report and you see infiltrates doesn't mean you can assign that diagnosis. This is information that you can use to build a query, right? Because the doctor could not, maybe not explicitly say the patient has pneumonia, but then when you look at the documentation, you're like, whoa, they were given antibiotics, they had infiltrates, their oxygen saturation was low, right? And that's the clinical indicators that you're reporting back to the doctor. You basically are telling them, giving them their own information and asking them to provide clarity. So, low oxygen saturation levels typically measured through pulse oximetry, which can indicate hypoxia. So, if you think about respiratory failure, we have those codes with or without hypoxia. We also have tachypnea, also known as rapid breathing, can indicate a respiratory diagnosis. Use of accessory muscles like the neck and the chest, suggesting increased work of breathing. So if you think about how you normally breathe, right, where your chest is rising and falling, use of accessory muscles like the neck and the chest indicate that the person is working overtime, right? Cough with sputum production. It can support diagnoses like pneumonia or bronchitis. A lot of times they will tell you what color it is, right? If it's colorful, it's suggesting something, right? So, all of these findings contribute to a clearer picture of the patient's respiratory status. Now, again, this is a review class. I cannot cover every little thing, but I'm trying to, in a 3 hour time span, cover as much as I can so that you can walk away with more than what you came with. All right, clinical indicators for the cardiovascular system. Um, I gave you a file that showed laboratory test results, normal versus abnormal. It's somewhere in Blackboard. Definitely, again, let me just reiterate. I don't know how long you're going to have access to Blackboard, so you need to download all files immediately. All right, so elevated troponin, that's a blood test, is a marker of myocardial infarction, like a heart attack. EKG, ECG changes such as ST elevation, ST depression, that points to an acute coronary syndrome. So you know how we got some codes that say STEMI and non-STEMI. That's what that's talking about. Symptoms like chest pain, in particular, when it's radiating to the arm or the jaw, raise concerns for ischemic events like a stroke. Newly detected heart murmurs could suggest a valvular disease. Blood pressure abnormalities could be severe hypertension or hypotension, um, require clinical attention. So that's all for the cardiovascular system. Let's keep on going. All right, so on to the gastrointestinal system. Abdominal pain or tenderness. That's common signs that you see in appendicitis, pancreatitis, or bowel obstruction. Nausea and vomiting, often associated with infections or obstructions or metabolic disturbances. And I should have put nausea, vomiting, and diarrhea. All right. Abnormal liver function tests could suggest hepatobiliary disease or some type of systemic infection. Imaging results like CT findings of a bowel obstruction, perforation, or pancreatitis. You may also see like some GI bleeding, right? They'll say things like hematemesis, hem, how do you say it? Emesis. This is basically vomiting of blood. Or melena, which is like black tarry stools. Those require diagnosis and treatment. All right, on to the nervous system. So, clinical indicators you may see are altered mental status, which ranges from like confusion to unresponsiveness, seizures. Seizure activity documented during admission or witnessed by staff can indicate a neurological condition. Changes in the Glasgow Coma Scale. So, in the signs and symptoms chapter, you know how we have those codes for the Glasgow Coma Scale? Um, those measurements reflect the different levels of consciousness and responsiveness. So, you know how it measures motor and eyes, etc. Focal neural deficits. This is stuff like unilateral weakness, slurred speech, or vision changes, often pointing toward stroke or brain injuries. Now, let me just be very clear. I am not a physician, I am not a nurse. I have gathered all of this data based on my own personal experiences and research. All right. Imaging abnormalities seen on a CT or MRI, such as ischemic infarcts, hemorrhages, or masses. I'll never forget, I took my father to the doctor. They told him to get an MRI. Um, we're leaving the doctor. By the time I get to his house to drop him off, which is 5 minutes from my house, the doctor's office called and said, report to the emergency room now. And that was because the MRI showed ischemic activity. He had had some strokes. All right. Next up, we have the kidney genital urinary system. So, an elevated creatinine and BUN is blood, urea, and nitrogen, suggests impaired renal function or acute kidney injury. They abbreviate that as AKI. Decreased urine output or too much urine, what's it called? Oliguria, classic sign of renal failure. Urinalysis findings such as proteinuria, which is protein in the urine, hematuria, which is blood in the urine, indicates underlying kidney or urinary tract disease. The presence of generalized edema is often seen in nephrotic syndrome or fluid overload states. And then electrolyte imbalances, such as hyperkalemia, can have a dangerous cardiac implication. So, again, as you're reading the documentation, and this takes time, the more you read, the better you will become at it. But as artificial intelligence comes into play and all the different systems that can do all the fancy things, remember your skill set will need to be on a higher level in order to be competitive. All right, we're going on to endocrine system. So, indicators of endocrine system dysfunction include hyperglycemia, so that's elevated blood glucose level. You see that in poorly controlled diabetes. Hypoglycemia, symptoms can be things like confusion, sweating, altered mental status. These often require immediate intervention. Abnormal thyroid function tests can suggest things like hypothyroidism or hyperthyroidism. And you know, it's so funny. I remember many years ago, we had our 10-year high school reunion, and I was planning it with a childhood friend who I hadn't seen in a while. And so the minute she came up on me, I was like, "Oh, you have Graves' disease?" And she was like, "How did you know?" And I said, I'm in the medical field, right? We hadn't seen each other, right? I said, so I'm in the medical field. I do medical coding. I was a medical assistant. And I know that the bulging eyes, also known as exophthalmos, is one of the signs, right? So she was like, whoa, I'm impressed. Clinical signs of diabetic ketoacidosis can include things like rapid deep breathing. And they have a word for those respirations. It's KUSSMAUL, Cosmal respirations. Fruity smelling breath caused by ketone production. Those indicators are some of what you will see in the endocrine system. Um, Also, as you guys know, let me just mention this while I'm thinking about it. So far, we're doing the domains out of order, right? But so far, we've done domain 1, we've done domain 4, we've done domain 5, now we're doing domain 3. In domain 3, the query process, I'm presenting these clinical indicators. When I do domain number 2, I am actually going to do a little anatomy review. And I bring that up because if you notice, I'm talking about these clinical indicators by system. And so and I had to break this up because it was just too much information. I want to present just the body systems and their structure and function, the different organs, just so you can put all this together. As you know, our sessions are recorded. I would highly recommend that you go back and review them. All right, so let's go on to the next system, which is the hematologic. So that's like the blood. So in the hematologic system, clinical indicators help identify disorders related to the blood's ability to carry oxygen, the clotting mechanisms, and defend against infection. So, when a patient has a low hemoglobin or a low hematocrit, it could suggest anemia and can result in symptoms such as fatigue, shortness of breath, or pallor. And you see that on the skin. Abnormal coagulation studies, such as an elevated INR, international nationalized ratio. um, a lot of times when they do a prothrombin time test, you'll see the INR. So those tests can raise concerns about bleeding risk or clotting disorders like DIC. And you know what? I realize I'm almost an hour in, so I cannot define every abbreviation. So look up DIC. DIC. Thrombocytopenia or a low platelet count, indicating an increased risk for spontaneous bleeding or the ability to form clots. Remember, I said you can't just be coding words, you got to know what the words mean. That's why I stated when you see a word that you don't know, if you look it up, you will start to learn it. So, clinical signs like bruising, petechiae, hematomas, or active bleeding sites also demand attention and clarification if they're not already addressed. All right, let's go on to the infections. So, infectious disease. So, in the infectious disease process, clinical indicators point to the body's inflammatory response to pathogens. Pathogens, you know what that word means from medical terminology. So, things you may see: a fever greater than 100.4 Fahrenheit, that is an early and sensitive indicator of a systemic infection. White blood cell count that's elevated, also known as leukocytosis, it is signaling that the body is fighting. It's signaling the body's immune response. Positive cultures from blood, urine, sputum, or wounds confirm the presence of specific organisms. And a lot of times, when they think the patient is having an infection, they'll put them on, they'll draw blood cultures, right? They'll get cultures, and then they'll put the patient on what is known as a broad spectrum antibiotic. And then when the culture comes back, they will know what the organism is and which antibiotic best treats that particular organism. Localized infection indicators such as redness, warmth, swelling, pus at the affected site. All of these indicate something is going on with the immune system. And there's, oh gosh, so much more I could cover. But again, there's not enough time because this is just a review, not an actual disease process course. All right, musculoskeletal. So, musculoskeletal system indicators support diagnoses of injuries or chronic disorders. So, you know how in the ICD 10 CM coding manual, we have the codes that start with a S. Those are our traumatic injuries. And then we have the codes that start with the M. There are some injury codes over there, but those are injuries that are due to disease. So those are, we call them the pathological fractures. So some clinical indicators, fractures confirmed on imaging like x-rays or CT scans, joint swelling or deformity, which often suggests arthritis, dislocation, trauma, decreased range of motion or stiffness observed during a physical exam, muscle weakness, which could result from different neuromuscular conditions such as inflammatory myopathies or disuse atrophy. So, disuse atrophy last year, September 2024, I fractured my ankle and I went to the doctor. I wasn't putting any weight on it. Um, Went to the doctor. He was like, let's see what happens. And I came back. The bone had not aligned like he thought it would. So I had to have surgery. So I had, after surgery, 6 weeks of non weight bearing. I did not use my left leg. I had disuse atrophy. It was and is a journey, and it's May 2025, to walk normally, to have the strength in that left ankle, all from not using it, using that leg. And so, one of the things I think about is, as coders, if you don't use your knowledge, you lose it, which is why it's so important that now all the way up to the exam that you're constantly reviewing the information. So these indicators can really help us, get accurate diagnoses for things like fractures, osteoarthritis, or muscular injuries. All right, next up, the integumentary system. So, the integumentary system covers the skin, hair, and nails, often reveals systemic or localized disease. So, pressure ulcers, as you know, those are categorized by stage and location. And it provides really important insight on the patient's level of mobility and care needs. And as it relates to ulcers, our codes are differentiated by body site and the depth. Burns, we need to know the degree, the size, the location, right? It's critical for us coding the severity, but also for treatment purposes. Wound infections, characterized by redness and swelling and drainage, increase warmth around the site. Rashes could signal allergic reaction, infection, autoimmune disorders. And so that's it for that. We'll take another break shortly, but I want to get through these. All right. Immune system. So, indicators in the immune system focus on signs of immune dysregulation, autoimmune diseases, or chronic inflammatory conditions. So, symptoms like chronic joint pain, rashes, persistent fatigue are often seen in autoimmune diseases like lupus or rheumatoid arthritis. Laboratory findings like a positive ANA, anti-nuclear antibiotic. Oh, I said I wasn't going to define these abbreviations for you, which supports a diagnosis of systemic autoimmune disorders. Elevated inflammatory markers such as CRP, which is C reactive protein, and ESR, erythrocyte sedimentation rate, reflects systemic inflammation. And it's so interesting. I think I might have told you guys this, but actually started off in healthcare as a medical assistant. And part of my training, we had to actually test blood for the ESR rate. And so I'm actually grateful for my experience as a medical assistant because it really helped me understand the clinical aspects. All right, psych and behavioral health. All right, some clinical indicators: positive depression screening results, which suggest the need for further psych eval or diagnoses. Symptoms of psychosis, such as auditory or visual hallucinations, delusions, or disorganized thinking. Documented suicidal ideation, right? Reports of severe anxiety attacks that impair daily functioning suggest things like panic disorder or generalized anxiety disorder. Now, you probably are wondering, why are you telling me these diseases? Well, after the break, we're going to talk about what you put in the query, and you need to have something to put in the query. Now, a lot of hospitals have pre, what do you call them? Pre templated queries, which will help, but it can't cover everything. All right. Okay, so that's enough for psych and behavioral health. Next up, obstetrics and gynecology. So, obstetrics is, when mom is pregnant, and gynecology is women. I have to say that because some people think they're one and the same. So, a positive pregnancy test confirmed through urine or serum testing, right? Fetal distress identified on electronic fetal monitoring, prompting immediate clinical intervention. I will never forget my first nephew um, was overdue. I think my sister was like 42 weeks pregnant. And when she was in the hospital, the fetal monitor showed that my nephew was in distress. And unfortunately, the staff did not um, respond fast enough, which resulted in some severe disabilities. And he lived to about 21, 22 years old, but had lots of disabilities as a result of um, they didn't properly do any clinical interventions. All right, let's see what else. Oh, signs of preeclampsia, such as hypertension, proteinuria, edema during pregnancy, all require some type of attention. And so I will tell you, I think I mentioned to you, I don't do day to day coding. I do audits for mid level providers, physician assistants, nurse practitioners. And so one of the things that I see in their documentation and coding is that they're saying, oh, this is a normal um, prenatal visit. But then they also assign a code for like preeclampsia. And so I have to, help them adjust their codes to align with the rules because they don't know the rules, right? All right. So we've made it to another point where I want to take a break. And so, as usual, the music will play. When the music finished playing, the the break is over. All right, we are going to get started. All right, so hopefully you guys enjoyed just that little brief introduction to clinical indicators. I have a few more things to say about clinical indicators, and they'll be in this next part. All right, so you've heard me mention compliant query over and over again. A compliant query must always be clear, concise, and neutral. It should never imply, suggest, or introduce a diagnosis not already supported by clinical evidence in the record. A compliant query should focus on solely clarifying existing documentation, offering reasonable choices without favoring one as the outcome, because that means you're leading. Reference specific clinical indicators or factual findings. Don't put assumptions. Following these principles ensures that the query remains compliant with the standards that are in that um, query guidance that AHIMA and ACTIS has put together. All right, so clinical indicators and queries. When writing queries, it is essential to directly tie your requests to observable evidence in the record. So, some examples of acceptable clinical indicators for queries could be laboratory values, such as elevated creatinine or elevated white blood cell count. Imaging findings like the pulmonary infiltrate or cerebral infarct in the MRI. Objective vital sign abnormalities such as fever, hypotension, tachycardia. In the inpatient setting, and when I do domain 2, I'll talk about the different forms that are in the medical record. Um, One of the forms is I'm going to call it a vital signs sheet, but I think there's a different name for it. But anyway, on that document, they generally are measuring vital signs like every 4 hours. And so you'll see over time what those vital signs are. And so vital sign abnormalities like fever, hypotension, tachycardia, um, are good things to include, but you got to make sure you put it all together by reading the entire record. You can also use things that you see in the exam, right? So at the end of the day, citing clear, specific clinical indicators strengthens the validity of your query and make sure it's ethical and compliant and is not based on reimbursement. All right, so how to include clinical indicators in your query? Well, number one, you have to be specific and factual. So avoid like vague language like labs abnormal. Instead, you want to cite exactly what you found and when. So, for example, you could say something like chest x ray from May 1st shows right lower lobe infiltrate consistent with blah, blah, blah. Precision and specificity helps the provider quickly understand what you are referencing without assumptions or confusion. Remember, clear documentation from you leads to stronger and faster responses. Now, let me just say, sometimes providers take a long time to respond, and there's nothing you can do about that. but you have to do your part. All right, so we talked about non-leading queries. Non-leading queries are a major part of a compliant query practice. A non-leading query does not, and I've said this before, and I intentionally made sure to repeat things over and over again. A non-leading query does not suggest, imply, or direct the provider toward a particular diagnosis, condition, or outcome. Instead, it's neutral. It presents the documented clinical evidence and is seeking to clarify or specify solely based on what's in that medical record. What you must understand is that the provider must be free to exercise their clinical judgment without any influence from your query wording. That's why I think a lot of organizations have query templates, because I think that it kind of helps with, number one, consistency in what the providers are seeing, but it also helps us do our jobs better. All right. Other and unable to determine options. Oh, and something I should tell you. What I've tried to do with this presentation is go through the major concepts that are in that purple file. Um, the query process file. But in a 3-hour time frame, I could not include everything that's in there. All right. So other and unable to determine options. In multiple choice queries, it is critical to always include an other. Please specify option. Why? This allows the provider to document a diagnosis that's not listed among the pre selected options. What does that do? Ensure that the query is neutral. Now, in yes no queries, you must offer an unable to determine, recognizing that sometimes they don't know, right? So, including these options protects you against the unintentional steering and leading, and supports the provider having that clinical autonomy. It was something I wanted to say here. Oh, so at this point, you should see two types of queries: multiple choice queries, and then the yes no query. So, types of queries, there's three types. There is the open ended, and the open ended, these request clarification in a narrative format, which basically is like free text, right? Multiple choice queries, they offer reasonable diagnostic options that you come up with based on the clinical evidence. And of course, you have to have that other choice. And then yes, no queries, these ask for confirmation when a diagnosis or situation is already included, but it just requires a simple verification. In the purple packet, the query guidance, they mention one reason for a query, yes, no query, is like a POA indicator. Each of those three types of queries definitely serve a distinct purpose, and the correct choice really depends on that particular case, that particular situation, and the documentation needs. All right, so let's look at a few types of open ended queries or query examples. So, the three types. So, open ended queries give providers the maximum flexibility to explain the clinical situation in their own words. So, example, please clarify the cause of anemia documented during this admission. Notice this type of query does not offer suggestions or options. It leaves it entirely up to the provider's clinical judgment and ensures that you remain neutral. All right, next up, a multiple choice query. Multiple choice queries can be provided in a structured format while maintaining that neutrality. In the query process guidance, they do give you sample queries. And so I did not really do too much in this presentation because I had so much other stuff to cover. All right, so please specify the type of pneumonia observed. So multiple choice: bacteria pneumonia, aspiration pneumonia, viral pneumonia, or other. Please specify. It is important that multiple choice queries only list diagnoses supported by the available clinical evidence and always includes other option to prevent limiting the provider's judgment. All right, and then the third type, which is that yes no queries. These are the most restrictive and they must be used carefully. They are appropriate only when seeking confirmation of a diagnosis, condition, or situation already suggested in the documentation. So here you see this example. Was sepsis present on admission? Yes, no, able to determine, unable to determine. Again, this format ensures that you are neutral and acknowledges that sometimes the provider may not know. And that's why we give them that out, unable to determine. All righty. We're we're almost at the point where we're going to get to the multiple choice questions. But just a couple of more rules for yes no queries. You must never introduce new information through a yes no format. You may only use a yes no query to confirm documentation that's already in the record. You must always offer up that unable to determine as a choice. Improper use of yes no queries can create compliance risks and make it seem like you are leading the provider. And what did we say from the beginning? Ethical compliant query. All right, so some best practices from for writing queries: be clear and concise. Avoid overly complex or confusing language. Just stick to the facts. Keep it simple. Maintain a professional, respectful tone throughout. Base the query solely on the facts. Just the facts, man. Just the facts. The documented clinical evidence and no assumptions. Avoid making interpretations. Oh, I got my little file here that shows the abnormal results. The patient's white blood cell count is elevated, so they have leukocytosis. You are not the physician. Even nurses and other clinicians that function as CDI professionals, they cannot lead the provider because they are not they're not treating the patient. And so they have to basically act in the same manner that we do. I think that is just so very important. Um Good query writing helps maintain integrity. It helps maintain the integrity. All right. There are some common pitfalls that can undermine having a compliant, ethical query practice. Leading the provider toward a desired diagnosis instead of seeking clarification. That's not compliant. Issuing queries without sufficient clinical indicators to justify the clarification. This is a concept that's known as fishing. You know, when you go fishing, you put the rod in there and you just waiting on something to come out. No, you don't do that. Over querying, query fatigue. When you send, first of all, it ruins our reputation with the doctors when you do this. So when you are sending unnecessary or repetitive queries, it can lead to query resistance, query fatigue. Um, you don't want the credibility of your queries to be at risk. And you have to make sure you have all the facts, right? So let's say you're looking at a medical record, the doctor ordered the echocardiogram. He doesn't have the results yet. He don't know what type of heart failure it is. So you have to understand the test. And that's why I've been trying to impress upon you all to not just not most, a lot of new coders just get caught up in looking up the words to get the number and don't have a clue what you're looking at. That is not going to fly as a future coding specialist. All right. Ooh, we are almost done. Escalation policies. So, if a provider does not respond to a query within your suspected time or expected time frame, you have to follow your organization's escalation policies. So, typical steps include, and they talk about this in the purple file, but typical steps include things like sending a polite reminder after the initial query deadline. Now, do you remember when we covered domain 4 regulatory? I showed you a video on the revenue cycle. And in that revenue cycle meeting, they talked about DNB, discharge not final bill, DNFB, discharge not final bill. Basically, just to review, what that means is the patient was seen, discharged, but we haven't dropped the bill. In that meeting, you saw, and this is covered in domain 4, you saw the meeting where they talked about the reasons why a final bill wasn't dropped. If we have a query out, our policy is going to dictate how long we hold out to get a response to that query. Okay. So let me see. So, sending a polite reminder, that's number one. Escalating to a physician advisor or documentation improvement leader. Thoroughly documenting all query attempts and escalations, right? You got to have proof that you tried to get in touch with the provider regarding that case. I also think it's important that providers understand the query process, right? They need to know that from time to time, we make contact them regarding clarification for the documentation so that they don't just ignore it and think it's not important. We want them to know that it's important. All right. So, wrapping up here with this first part, and after this, we will take another break so we can transition into the multiple choice questions, which I anticipate will take another 30 minutes to get through those because I want to make sure I give you the rationales and all of that. So I couldn't put the entire scenario on the slide because I didn't want it to be too busy. So I'll just cover some background information. So we have a chest x ray that reveals infiltrates, suggesting some type of lung infection, pneumonia, but the provider's documentation doesn't explicitly diagnose or mention any corresponding treatment. In this case, a compliant query is appropriate to clarify the clinical significance of the infiltrate. Um, the query should ask whether the provider clinically diagnosed pneumonia or another condition based on the imaging and the symptoms. So you need to present all the facts, right? So In the Merck manual, one of the things they talk about is, for each disease, they go over the signs and symptoms, etc. And so you need to put the pieces together to present, right? Not just say, "Oh, only thing I saw was the X-ray had infiltrates." There should be some other clinical indicators, which is why I went over those. Okay. So, clarifying this ensures accurate coding and complete clinical documentation. All right, next scenario. So, provider documents chronic kidney disease but does not specify the stage. And coding guidelines, as you guys know, require us to assign the code for the stage 3, 4, 5, 1, 2, whatever. The stage reflects the severity of kidney dysfunction and other significant implications for treatment, prognosis, and quality reporting. So a compliant query, and again, everything is based on the documentation that you have in front of you. So don't try to take these slides and make a query. You need to use what's in your medical record. So in this particular situation, a compliant query is needed to request clarification of the stage. And in the documentation, the nephrologist could say what the patient's glomerular filtration rate is, GFR. And so if you Google GFR rates, you'll see that they are typically connected to a stage. But again, you can't just automatically assign a code for the stage. The doctor has to give you that information. All right, next up, heart failure. We talked about this multiple times. So, heart failure documented in the record, but the type is unspecified. And so, we need to know, is it systolic? Remember, I said, and you should look this up. If you look up echocardiogram and ejection fraction, you'll see that it'll tell you that if the patient has reduced ejection fraction, that's systolic heart failure. If they have preserved ejection fraction, that's often diastolic. And then we have combined and diastolic. So, right, those are words that you see in the code book in the I-50 category. But you also see things like acute, chronic, acute on chronic. So, a compliant query will request the provider to specify the type and the acuity based on available clinical evidence, right? So, you got the echocardiogram findings, and you basically are providing him with that information. All right. Let me say this. So I just told you words like um what did I say? Reserved or preserved. Oh, preserved ejection fraction reduced, right? Um don't make your query where you're boxing him into a systolic only because you saw reduced ejection fraction. You still have to present him with the findings and ask the questions like, systolic, diastolic, all that good stuff. Okay. Um, and I think AHIMA used to have some query templates. I don't know what happened to them. I'll have to look on my computer. I deleted a bunch of files on my computer, so I may not have them anymore. But they used to have some really cool query templates, and more than likely they still have them, but you can only access them behind the membership wall. All right. Ooh, we are almost done. I have 5 scenarios. All right. So, scenario number 4, dietitian assessment identifies severe malnutrition using objective clinical criteria such as weight loss, reduced food intake, or muscle wasting. These are all indicators of malnutrition, severe malnutrition. However, the provider hasn't even documented malnutrition. Um, Coding rules state Malnutrition can only be coded when documented by a licensed independent provider. So, a compliant query would request the provider to review the clinical findings and clarify whether they clinically agree with the diagnosis of severe malnutrition. And if confirmed, the provider should explicitly document the diagnosis and ideally state if it's mild, moderate, or severe, because that's going to help with those E43 codes or 44 or something like that. I try not to memorize codes. Sometimes you can't help it. All right. And our last scenario, sepsis. Sepsis, I think, is a very controversial condition in our industry because the criteria, I think, changes. And so it makes it a little complicated. But nonetheless, um, clinical signs suggest the presence of sepsis. What clinical signs? Fever, elevated white blood count. They'll say white blood count shift to the left or something like that. Tachycardia, hypotension, organ dysfunction. And if you look at these, you're like, wait a minute. Oh, it makes sense because in the guidelines, we talk about sepsis and severe sepsis and that organ dysfunction. So all these clinical indicators should make sense as to why we need to know. So, but in this case, the provider documentation does not state where the sepsis was diagnosed, and sepsis coding requires them to document it, right? Clinical presentation alone is not sufficient. The doctor has to say it. So, a compliant query should ask the provider to clarify whether they diagnosed sepsis during the encounter based on documented clinical indicators. So, a clear documentation of sepsis not only uh, impacts coding, but it also helps with quality and mortality because somebody can die because of being septic. Whew. All right, guys. So it is now time. Let's do another break. And then we're going to get into some multiple choice questions. All right. So we are at the last part of today's discussion on provider queries. And this last part is going to focus on some multiple choice questions. I do want to give a disclaimer that the reference document that was used to generate the quiz questions are from the AHIMA ACTIS document. And I will try to remember to call out the page numbers that supports the correct answer. And then there may be one or two questions that my reference was the guidelines because I could not find anything that is in the query process guidelines. One of the things that I know to be true is that in order to be able to execute this process, the very first thing that you have to be able to do is understand it. So, definitely, I know I've said this multiple times, but definitely print out the query process document and read it a couple of times, just like the guidelines. I've had several people say to me that they didn't do this, and when they went to take the CCS exam, they struggled with these questions. Please remember that AHIMA has told us what we need to know from the perspective of the floor. I keep saying that as well. So you just need to make sure that you are over prepared as opposed to under prepared. All right, so we are going to go into the questions. So the first question is, what is the primary purpose of a provider query? All right. So if you said answer B, clarify ambiguous, conflicting, or incomplete documentation, you were correct. According to page 5 of the query practice document, queries ensure documentation accuracy and not coding integrity, not financial gain, right? We don't ever want to query for financial reasons. On to the next question. Which of the following best describes a compliant query? All right. So if you said C, neutral and based on clinical indicators, you are correct. According to page 6, queries must be objective, based on clinical facts, and avoid steering the provider in one direction or another. On to the next question. Which document provides national standards for compliant queries? All right. So the correct answer is A, the AHIMA ACTIS guidelines. So, one of the things that I do want to make you aware of, these guidelines represent the most recent version, and you should avoid using an older version because there were some changes to these guidelines and you don't want to try to apply old rules. All right. Let's see. What was my page number for this? I think this is page 2, and this is the Joint National Standard created specifically to guide compliant query practices. All right, the next question. Which is an example of clinical indicators? Okay, so if you said C, lab results, imaging reports, and physical exam findings, you are correct. According to page 9 of the query process, clinical indicators are objective signs supporting a diagnosis like labs and imaging. Next question. What type of query allows the provider to explain their answer freely? All right. If you said C, open ended, you are correct. According to page 11, open ended queries allow the provider to elaborate in free text without being led by the person who is sending the query. All right, on to the next question. What type of query, which query type must always include an unable to determine option? If you said B, yes, no, you are correct. According to somewhere around pages 5 and 6, yes, no queries require an unable to determine option for neutrality. They don't want you to have any influence whatsoever. All right, next question. When issuing a multiple choice query, which option must be included? Okay, if you said B, other, please specify. You are correct. According to page 5, other, please specify, allows providers to document conditions that are not listed. Next question. When is it inappropriate to issue a query? All right. If you said C, you are correct. According to page 6, queries must be driven by documentation needs, not financial motives or financial incentives. On to the next question. Which of the following is not a reason to send a query? All right. If you said C, increase billing amount, you are correct. According to pages 2 and 3, when they talk about the purpose of the query, queries clarify documentation for accuracy, not for financial gain. Next question. In which situation is a yes, no query appropriate? All right. So if you said B, confirming a POA status, you are correct. According to page 12, yes, no queries can clarify POA status or the specifics of a already documented diagnoses. And let's go on to the next question. What must queries never mention? If you said B, quality measures, you are correct. According to page 5, impact on reimbursement, quality measures, or other reportable data must not be included. On to the next question. Which option describes clinical validation? If you said A, you are correct. According to page 7, clinical validation ensures documented diagnoses are supported by clinical evidence. On to the next question. If documentation is clear, but reimbursement could improve, you should. All right. If you said C, do not issue a query, you are correct. According to page 5, no query is needed if the documentation is already complete and accurate. On to the next question. Which of the following can be clinical indicators? All right. If you said B, blood pressure readings, you are correct. Vital signs like blood pressure are considered clinical indicators. This is page number 9. Next question. Verbal queries must be. All right. If you said A, documented in the health record or retrievable, you are correct. According to page 11, and just in case I have these page numbers off, you should still be able to find the area that they're in. So, according to page 11, verbal queries must be documented or discoverable. And I think I mentioned this already, but I want to just reiterate that organizations use the query document to create their own internal policies because you know that every organization has their own, systems and processes, so they have to tailor it to their work. All right, next question. What is query fatigue? All right. If you said A, repeated queries causing providers to ignore or resist, you are correct. According to page 6, repeated unnecessary queries cause providers to disengage. This is one of the reasons why it is important that you, as the coder, have an understanding of the language of medicine. All right. Next question. What should queries always cite? All right. If you said C, specific clinical facts from the medical record, you are correct. According to page 9, specific clinical facts from the medical record should be cited. All right. Next question. What is a leading query? All right. If you said a question suggesting a diagnosis or answer, you are correct. According to page 6, a query that suggests or leads to a specific diagnosis is non compliant. You don't want to do it. All right. Next question. What happens if a query is answered and documented correctly. All right. If you said A, no further documentation is needed elsewhere in the record, you are correct. One of the things that I really want you guys to understand is that even if the first answer looks like it's the correct answer, look at the rest of the answers to make sure that there isn't one that is the best answer, but then also don't second guess yourself. Keep in mind that on the CCS exam, you can't mark the question and go back. When it appears on the screen, you must answer it. And you don't know if you got it wrong or right. So, no further documentation is needed elsewhere if the query is complete and compliant. That's page 12 of the query process document. Next question. Which format is generally preferred for queries? All right. If you said B, clear, open ended, or clinically supported multiple choice, you are correct. According to page 12, open ended or clinically supported multiple choice questions are preferred. Next question. Information from a prior encounter can be used to query if. All right. If you said answer choice A, it supports the current clinical scenario, you are correct. According to pages 8 and 9, it supports the clinical scenario of the current encounter. All right, next question. A coder finds conflicting diagnoses in the chart. What should they do? Now, this particular one, the only answer choice that is compliant is to query the attending physician. However, I am pretty sure the query process guidelines talks about like if the person who is, let's say it's a specialist that saw the provider, um you should, if they're the ones that's doing the conflicting, I believe the query guidelines state you should contact them. I'll have to double check that, but I'm pretty sure. All right. Which of the following is a non compliant practice? All right. If you said answer choice B, repeating the same query to multiple providers until one agrees, you are correct. Repeating the same query until the desired answer is received is non-compliant. Page 6 of the query process. All right. Next question. What should be included in every query template? All right. If you said B, clinical indicators with their sources, you are correct. And I want to pause for a second and go to, oh, let me give you a rationale for that last one. Um, Page 7, clinical indicators and references to the health record evidence are important. All right, so let me, oh, actually, the guidelines do say that. When conflicting documentation is present, the attending provider should be queried to resolve any discrepancies. Um, so, what the document says is that this has been expanded and updated as of 2022. So that's where it was some confusion in my brain because it changed. All right, that's why keeping up to date is critical. I currently do not query providers because I'm not currently coding. All right, so I do more of education. And so I'm not in a position to query them. Um, I just try to get them to document properly. All right. Next question. Um, how should technology generated queries be treated? All right. If you said C, like any other query, must meet all compliance standards, you are correct. According to page 1415, they must meet all compliance standards like any manual query. So I think also, excuse me, it's important to note that you want to double check to make sure that any technology that you're using that it is compliant. All right, we're almost done. If the provider documents likely pneumonia, what type of um in the inpatient setting, I should note that. This question is about inpatient. What should the coder do? And this isn't even a query question, but because it's really guidelines. All right. So the answer is code the pneumonia as confirmed without needing a query. So I guess as I was putting together these questions, I was trying to pull directly from the document. So yeah, this is appropriate because you shouldn't query when when the guidelines tells us that this is acceptable. All right, next up. If a diagnosis is ruled out, what should the coder do? All right. So the answer is C. Do not code the diagnoses. All right. We do not code something that was ruled out. All right. We're almost done. Next question. Which professional groups must understand compliant queries? All right. If you said B, coders, CDI specialists, auditors, and compliance officers. This is page 2 from the query process. All right. Next question. Which situation needs a query? All right. The answer is A. The provider documents infection, but no site is specified. When the documentation says infection, but no site is specified, that is a reason to query per pages 5 and 6. And the very last question, why must queries be kept neutral? All right. If you said B, to prevent accusations of fraud and ensure honest clarification, you are correct. That is from page number 5. All right. So we have just wrapped up going over the query process. I would encourage you to read the query process document multiple times. In the guidelines themselves, they tell us when to query. And so you have the tools that you need. You just got to use them.